So allow me to introduce our lead presenter today, Ms. Oreta Tupola, and her team of CHWs. Oreta, the time is yours. Thank you so much.
Sorry, did I make you guys dizzy? Sorry. I should have put that on earlier. Can you guys see my screen?
Yes.
Okay,
Yes.
cool. I want to thank you all for being here and especially for this topic. When the topic came up and we were looking to see who was interested in facilitating this, I was anxiously like hoping that I could lead on this just because of the work that I'm doing. So I would just say my name is Oreta Tupola. I am the director of the Utah Community Health Worker Association. Background is in social work, and I've been doing community health work and building the infrastructure for community health workers in the state of Utah for the past 9 years. And we have been fortunate to connect with Dr. Lopez and her team to provide these kinds of sessions around different topics that have been either stigma or lack awareness in the communities that we serve, diverse communities that we serve. So the community health workers that are all here, I'm grateful they're here. They will share more stories, but today's topic is, like Tatiana said, on mental health with a focus on men's mental health. And I just wanted to share why this was such a huge topic for me that I wanted to lead on. Did it change? Okay. So this is my family. This is my husband, and just some pictures of, we are high school sweethearts. So we went to school together in high school, and then we had our kids, and then I was a non-traditional student that went back to school for to study social work. It was always my field of practice. I knew that's where I would be, just dealing with a lot of the things in my upbringing. I come from a small town on the North Shore of Oahu in Hawaii, and I am of Samoan descent, and my husband is Tongan. And so without going into real detail about those cultural factors and how they impact our perspective of health and mental health especially, I wanted to just share why this is such a passionate subject for me to speak on. I think you'll hear support of what I'm sharing in the sharing of the CHWs, and also from the data that we will share as well. My husband is of Tongan descent. Like I said, he was born in Tonga and then came to California by way of Canada and Samoa when he was, I think, 9 years old. He's very active, rugby player, played football, played a lot of sports, but grew up in a family where construction, they did a lot of construction and labor work. And so their family had a construction business, and he grew up from when he was a child going to work with his parents. His father was a graduate from Liahona High School, and then he went to college in Fiji, and he became the director of agriculture for the King's Farm in Tonga, and then carried on that work to the United States. On Hawaii, he ran the farm, the King's Farm. So I share that to say, he was used to doing a lot of labor and work, and his expertise was in that field of construction and labor, right? When we got married, which was at a very young age, he continued to do that work, and then, went into the field of, did some work of maintenance, and then in order to elevate his skills, he did a lot of apprenticeship work and got his certificate and became a line tech for the church through Zion's security, and then that became Hawaii Reserves Inc. And the big company here, Jacobson, moved to Hawaii to build out our sewer system and all the things there. And he was one of the line techs that helped to put in the water pipes, change the old water pipes and all of that. Anytime there was a leak in Laie, he was there. So he was always jumping into holes and jumping out of holes, and to fix the water pipes or any leaks that happened within our community. The community is called Laie, is a city of refuge by history. On the Hawaiian Islands, it was a place where people would find refuge when they were being, I don't know, they were in trouble with something, and they could find safe space in this home. And that became the home where missionaries went and built the church there. The temple is there, and BYU Hawaii is also located in this area. So everything that's managed in that area is by Hawaii Reserves Inc. So anyways, I share this because again, he lived a very active life, very engaged in a lot of things, different things, sports, especially raising our two sons. And he got injured at work by carrying a piece of equipment that for the cranes that they operate, and lifted it and put it into the truck. And then he hurt his back. So his back was dislocated. And then from there on, it's been a downhill road, especially for our family in experiencing this shift, right? I was a stay-at-home mom. I took care of all of my children while he was working and providing. And in our culture, this is very common. Well, I won't share too much about the culture because it'll come up in the Pacific Island piece. But because of the expectations and then the stigma and the cultural impact on our males as the head of household and the provider, he had gone through a lot of things that we didn't expect as a family because of this switch now of roles. Gender roles are very important in our culture. And when this had happened, it forced me to have to go back to school and then become the provider, and we switched places. And so in that whole process, he has gone through anxiety. He has gained a lot of weight because he can't do anything. He can't physically do anything. We've applied, just had to go through the system and face a lot of barriers and judgment as he goes to see medical providers to say, hey, I'm hurting. I don't want to get hooked on painkillers, but I do need some kind of relief for my back, for my injury. They sent him to physical therapy. That didn't work, and then ended up in aqua therapy, which kind of helped with his physical movement. But in this whole process, he just had to deal with a lot. I had heard about people struggling in their marriages around provider, around females or wives making more money than their husbands. And in this experience, we went through a lot of that, just struggling to deal with what the situation was. And so again, now he's dealing with anxiety. He can't be around people all the time. There's just a self-consciousness that he has about now who he is because of all of this change, right? And then he had gained a lot of weight through this process and couldn't do a lot of things that he used to just do, normally. And now not being able to do any of it has been very frustrating for him. So in that process also has been diagnosed with depression. And mind you, we didn't talk about this. This was in 2012. And all the way until 2016, when my second daughter graduated and we moved here to Utah, we had not talked about any of the mental health issues that he had been experiencing, because he was still processing what that meant. At the same time, I was dealing with not knowing where all this attitude was coming from, where all the the resistance was coming from when we would try to work on things. We were always fighting. It just really impacted our marriage. And it wasn't until we had moved that we started to just openly talk about these experiences. And again, it was just like a tidal wave that hit our family, and we were drowning. We didn't know where to go or where to turn to, because he couldn't speak to his father or to other males in their family, because they had that same perspective of mental health, that it doesn't exist, that this is you just being weak. You need to get your mind straight and then focus on what you need to do to continue providing for your family, because you're the provider. um, Meanwhile, I was in school and trying to do all of these other things to support him, but really getting a lot of the backlash of this all from his family, from my family, from him as well, just because everybody's now processing this change. Meanwhile, my kids are also being impacted because they don't know what's going on. They're just trying to go to school and do what kids do, yet we're all just trying to figure this out. Anyways, fast forward. There have been points in my own life where my mental health has struggled because he couldn't talk about these things. And this became clear to me that he wasn't the only one going through this. And so as I got in more into my work and the work that I do in social services and violence prevention, I was hearing more and more Pacific Island men sharing these same kinds of experiences, not being able to speak on this, that it's something taboo that we don't talk about. And just the shame also of not being able to provide, not being the provider, or the wife working and the man not be, providing for their family. So anyways, that's how this became a topic that I was very interested in, because I wanted to really support my husband and be able to talk to him and make him feel like, there are other ways that you contribute to our marriage and to our family than just monetarily. And that is valuable too, to our marriage and to what we're trying to build. We can still build and do all of these things, even though the roles have switched. But it took us a long time. I mean, I will say several discussions of divorce, several discussions of separation, so many things, right? Until we were able to just be open. And we really did hit rock bottom as a family, trying to discuss these mental health things, because we felt like there was no one else who could support us, because our families have this same kind of perspective. That's where it came from. So anyways, I share this to open up this presentation for you to also think about people in your family that may have experienced, even yourselves that may have experienced similar things and have not been able to speak up about them. Our goal here is to just spread more awareness about why this has been such a big stigma, to spread awareness about just how prevalent it is in our communities, and how much the numbers of mental health in men have risen in the past couple of years, and they continue to rise. And I feel like it's because we're not able to speak on this and openly talk about this, especially with our men. So anyways, if you guys have any questions or comments that you want to share, please go ahead and unmute. We really want this to be more discussion than us sharing, but at the same time, we do want to share our experiences around this, so that you are more aware as you go out into the field about how important this topic is, and how much it still is a stigma. There still is a stigma around this issue. I don't know why I was so nervous. Maybe it's just because I'm talking about my own family. But usually in these presentations, I can just go with the flow. But if anyone has any comments or they want to share about anything, please go ahead and share. The next few slides are going to be on just data around mental health. And if you see the US population of males and then how many are affected by depression per year, that should already be alarming for you. This information you can find on mental health, Men's Mental Health America. That website and the references will be shared at the end of these slides. But again, 1 in 5 adults experience a mental health problem each year, and the cost of mental health, if you just think again about your personal experiences or what you know around healthcare costs in general, this is a lot of money that we're spending around this, or people are having to spend. And if you think about also the communities you may come from, and especially for our CHWs, the communities that we serve, it's not something that's affordable for many. If they decide to even look for help or seek help, it's not affordable for them. 5 of the major mental health problems affecting men are depression, anxiety, 2 of which I've already mentioned my husband experienced, bipolar disorder, psychosis and schizophrenia, and then eating disorders. I mean, that was something I felt like, oh, that was a surprise to me, the eating disorders. Again, you'll have these slides so you can look at the more detailed data around these major mental health diagnoses, but these are the 5 that are high prevalence that our men are experiencing. And then, facts around suicide. These are the populations that it mostly affects. So our elderly, it's mostly found in males over the age of 85. Our male suicides are on the rise. It's the 7th leading cause of death among our males. Gay and bisexual men are more likely to develop mental health disorders than heterosexual men. And then it shares the risk factors. So social isolation, substance abuse, unemployment, military-related trauma, genetic predisposition, and other mood disorders put people in a higher risk for suicide. And then the gender disparity is that it happens 4 times more with our men as they do with our women. Substance abuse is a huge risk factor. So alcohol dependency, 1 in 5 men develop alcohol dependency during their lives. Our homosexual men are more likely to have higher rates than our heterosexual men. And then our veterans, again, regardless of where they serve, they are nearly twice the rate of alcohol and drug dependence as women. These next 2 slides just share the different. There's no discrimination when it comes to mental health and the men that experience this. And these are athletes who experienced this. And when they had found this out, many of them, this wasn't discussed or publicly announced. They either found out and then they tried to figure out and process what it was and then deal with it. And then later it came out when it was, when they were ready to speak on it and their experiences. But for many of the athletes, it's due to different things, and we'll share some examples later on. Depression is a huge one that is experienced among these athletes. By borderline personality disorder, PTSD, these are just different. They play football, basketball, and baseball, but almost all the same, very similar diagnoses. So again, bipolar disorder, PTSD, a post-traumatic stress disorder, and then depression, and anxiety. That was the other one. So the 5 major ones that we mentioned, these athletes experience just that. And the reason why these statistics are important for you to think about and remember is that when we start talking about individual cultures, you're going to see the pattern of these same diagnoses and the same data showing up in that sharing. Just some science around mental health. So low levels of testosterone are correlated with depression, stress, and mood swings, especially among older men. And then when it comes to seeking treatment, again, men are less likely than women to seek help for depression in all of these diagnoses because of social norms, reluctance to talk, and then downplaying symptoms. Again, we'll speak more in depth about that. this is just the reference sheet. Does anyone have any questions about any of the data that's shown? Are you alarmed? You can answer or share thoughts, or you can put a thumbs up on your screen if you are aware that this was the data around men and mental health and why they don't seek help for it. Any comments around any of the data that was shared?
I was alarmed by the data that you mentioned about the highest suicide rate among the age 85 years old with the white Caucasians. I did not know that.
Yeah, it was alarming for us. We do a lot of suicide work with youth, and we know that the percentages are higher in boys than girls, or males than females. But that was alarming for me too, is the age. And then when we had talked to some of our elderly and to some of our experts who are working in this space of suicide, they did mention just again struggling with the stage of that life and that age in life, if they're dealing with things, the transition of becoming elderly or not having family support, and just and not having resources that they needed to at that age to live healthier lives. That those were a lot of signs that they seen, or symptoms that they seen, that were a cause for that in that age group. Any other thank you for sharing that. Any other comments?
Yeah, I have one. I mean, I always think about how underreported it is, on the fact of all these things that we're not catching. Like, I know somebody who got a spinal cord injury and took their life after, and this person was male, and they, like, just the downward spiral to be able to see from that, and to be able to like watch the fact of, so many things were taken away, and how much of this person was amazing, but how much of their own self-worth they saw within the lack of not being able to be as functional as they thought they should be, versus and feeling like a burden on people's lives.
Yeah, thank you so much for sharing that. It really hits home for me, because that's exactly what happened with my husband. And just not no the it was just hurtful that people would make comments like it's such a small thing, like you're not dead, things like that. Or just they would just make comments around how you should just get over it. It wasn't helpful for him. And so even though he didn't speak on it, even more, he suppressed a lot of the feelings and the things that he was going through. He didn't want to share because of those kinds of stigma. And also just, again, his self-identity was really based around his ability to provide and to work and to do all these things. That's all he knew from when he was 10 years old, working construction with his family. And then to go to this state of not being able to do any of it. Like right now, we had gone through Social Security benefits to try to get him some help, and to get our family some help, because now I have several jobs to try to provide for us. And they kept saying it's because you're so big, and then because he's Polynesian, that his weight is what the issue is. It's not his injury. And so just being judged every time he went in, he refuses to go to the doctor, because that's what they keep telling him, is that you're too heavy, you need to lose weight. And then we went to one doctor who said, I know people who are like 130 pounds who have back injuries and they can't do anything, who have disability, are disabled. And so we thought, oh, we have some hope. But then to go through SSI 6 times now, we've applied and gone through the system and got denied. That was even hard too. And now we're trying again because we need that help. And he doesn't want to, because they're saying you have to have a tracking of you going to see a medical doctor to document that you're in pain and that you're seeing somebody about it and all of these things. But his anxiety is so bad that we can't even get him to go anywhere. He just stays in his room and he doesn't come out. So I thank you for sharing that, because isolation is a huge thing. and he's been isolating now himself, and it does get very lonely, even though there's so many of us around him. That isolation piece is very real, and it has led to many deaths I've heard of. As we speak out more about this from other people who have gone through this and said, you know, we didn't think it was a big thing, and now they're gone. We wish we could have talked about it. So thank you for sharing that. Any other comments? CHWs, please jump in if you have anything to share. I want to switch the time over to Felian for Utah data. I put this slide in actually just to show the difference in you know, who this impacts more than, and it shows that males are clearly experiencing this a lot more. But when you talk about, is it Carrie? Or is that how you say your name? Yeah, Carrie, when you talk about unreported, things that are unreported, I mean, I definitely think these numbers are higher because our men don't talk about it and they don't say that this is an issue. Celianne, from your next slide.
Yeah, thanks, Areta. Yeah, so next slide, yeah. So the Office of Health Equity recently released some reports on racial ethnic minorities of the 20 years of health data for the minority group. So this first data is about Native Hawaiian Pacific Islander communities in Utah. Again, as Areta mentioned, we don't have all the data. This is just of the people that were in our analysis. And so you can see from this chart here that Native Hawaiian Pacific Islanders are 23.2% of for recent poor mental health compared to the Utah overall of 19%. And then you can also see that it has increased over the years since 2005. Next slide, please. So this one, we look at the Black African American communities in Utah. Again, it decreased from 2005 to 2010, and then kind of stayed the same, and then increased in 2021, and it is 21.4% compared to Utah overall of 19%. Next slide, please. So in this one, we're looking at the American Indian Alaska Native communities in Utah. Here, the communities that we have in our database, it started high, and then it decreased, but by 2% now, and then compared to Utah, it is higher. Next slide, please. So for the Asian American communities in Utah, it's lower than the Utah overall, and at 16% versus 19%. Next slide. And then we have the Hispanic Latino communities in Utah, where they started back in 2005 a little higher than Utah, and then have decreased now in this 2021 report, and whereas Utah is at 19%. Again, this data isn't accurate because we don't have all of the data that should be in this analysis, but this is what the Utah Department of Health and Human Services has analyzed for these communities. So now I'll turn the time over to, I believe, Miss Kathy is first about the cultural perspectives.
Mm-hmm.
Thank you.
Good evening. I'm Kathy Wolfsfeld, and I represent the African American community. And the men in our community are very, I don't want to say macho, but they have that background where they need to stay strong and be strong. And they look at mental illness is a weakness. And so mental health in the African American community is not a topic that we like to discuss. There's a taboo about going to a therapist. Men view it as a personal weakness, running counter to the survivalist mentality born from systemic oppression and chronic racism, or even a punishment from God. We are very, very church-oriented, church-centered, God-centered. And some do think that this is a punishment, you know, especially the older African Americans think that, you know, you must have done something wrong, that you're, you know, going through all of this, or, you know, depression is just not talked about. Even though it runs rampant, men are trying to just stay strong. They don't want to seem weak. And so that's the main reason why, you know, men just don't talk about, they don't want to seek therapy. It's not a common occurrence for men to seek out a therapist. He might do it if he is married and his wife is insisting, or, you know, maybe his medical doctor or something might ask him to see someone, to talk to someone, but it's not a common thing. That's about all I have to say about the African American man. They're just too strong and or think that they're too strong. You know, they do equate mental strength with worth. And, you know, if they're not able to provide for their families, then they don't feel that they're worth anything. But they don't like to talk about it. And so that's a big thing about trying to get them help and trying to get them to open up.
Thank you, Ms. Kathy. And if anyone has specific questions or comments around any of the specific communities we share on, again, please go ahead and unmute and share. Now we will turn the time over to our Latino community.
Yeah, thank you, Rita. And with me is Tatiana and Sarah and Jenny, if they want to add something about the Latin community, Hispanic community, Latinx community. Well, as many say about us, mental health in men is very is a little bit challenging and unique, because mental health for the Hispanic men start from the moment that they decide to move to this country. From that moment, the mental health start having challenges because they are not feeling enough to provide for their families in their own country. And then the travel journey to come all the way here is some of them, they pass to trauma during that travel. And when they come here, they have their anxiety levels very high. The cortisol is very high, that they don't notice any, they cannot identify any symptoms at all. And they continue living because they don't have time to do that because of the the gender roles. In the Hispanic community, the men are the providers. They are the ones that have to take care of the family. That's why I put you here so many of the key points, right? The stigma, as Kathy was saying, this is something in common, I think, in our communities, that the stigma that we don't talk about mental health. We don't talk about the symptoms. We don't talk about treatment, because we don't have time for that. Men in our community, they have 2-3 jobs. They have to provide. They don't talk about themselves or their feelings. There's a stigma and the cultural norms. And then the language barrier to talk about, you know, it's a stigma to talk about mental health, and to talk about mental health in another language that is not mine, I cannot express myself better. It is hard. It's better not to look for services. This is a very for look for services. You know, the underutilization of services is this, because sometimes they have access to to education about mental health, but they decide not to do it because of the stigma, because if they say something about mental health in their jobs, they are feel afraid that they're gonna get fired because this is something that you don't talk at your job. In a home, you don't talk about that because as Kathy was saying, this is a signal of you're weak, right? And you're not enough to provide for your family. And they keep silent. They don't talk about that. There's socioeconomic factors, they work, many in our community, they work in constructions. They don't have enough to pay $200 for a visit in a mental health because of the lack of insurance. It is a service that is so expensive to access to therapy. They prefer to use it in another needs that they have. The immigration stress, to feel every day that you can be caught by immigration and be deported to your country and leave your family here, your kids and everything. That is something that collaborate with the mental health. And in our community, another factor that is very common is the substance use, because in our community is, is culturally, it's okay for you to drink in the weekends, and sometimes they don't see the relation between substance use and mental health, and they use it as a coping skills, right? Like, oh, it's just the weekend, but it's every weekend, and they don't see that connection. They need a lot of education on that level to really relate mental health with substance use, because of the lack of awareness on mental health literacy, right? Something that they can really, in the level and the language that can really explain. In our community, is not easy to talk about. Orita was talking about bipolar. A lot of people in our community don't know what is that, how we feel, what are the symptoms. They don't recognize the anxiety level. They say, I'm stressed, but maybe it's not stress, it's anxiety. And there is a lot of lack of that literacy in our community. As I said, the gender roles and the community family support, there is so many classes now in our community that provide that education about mental health. And even though that they receive that support in education, they are still receiving that education because it's helping somebody else, not for me. And with men, it is even harder because, as I said, they are the machos, in our culture is like the machismo, like this is the man. The man cannot be weak or cannot show that weakness. And I think that everything is collaborate to increase the mental health issues in our community. And it's very similar for Kathy was saying about the taboo, the looking for services, the lack of providers in our own language. It is hard to find a provider that speaks the language. I don't know if I'm missing something, but if anyone can add something to this, will be good. Thank you.
I could add, Janet, that it is not a priority. Prevention of mental health is not considered part of the priority in our community too. We see a lot of men going to the ER or the emergency room, and they already have an advanced disease because they never consider going to the doctor before. And mental health is not part of the care. They always put mental health as like the stigma, with the stigma, like it's not important to consider going to a mental health provider. That is huge in a lot of our communities, and for sure to the Hispanic community.
Thank you, Jenny and Jeanette. We'll go to Ivana.
Well, hello everybody. Can you hear me? Sorry, my computer was glitching a little bit. Okay, cool. Hello, Yate, Ivana Holiday. So mental health in Native community, as like stated in on the slide, So many of the issues are like depression, suicide, and addiction. So substance abuse are the results of hopelessness, anxiety, and despair. And then most of the time with mental health issues, it's linked to trauma in a person's life or within his family. So some of that trauma can be multi-generational. And with multi-generational, so it's like Indian boarding schools, forced removal off their traditional lands, taking resources off their tribal lands, a lot of environmental impacts, and then just moving off the reservation too. So many like what Areta, Jeanette, and Kathy were saying, like in their communities and then within the Native community, like Native men were raised to believe that they have to be tough, they can't show their emotions, they have to be the provider or the protector to their family. So mental health doesn't, like their mental health issues isn't uphold, they don't uphold that image if they consider themselves having mental health issues. And a lot of like the factors that influence men's mental health, so like taboo. So within the Native community, it's taboo to talk about suicide, to talk about death, to talk about those like negative aspects of life. And then toxic masculinity. So a lot of Native men feel like they have to uphold this image, and that talking about their feelings, they're seen as emotional people like that. And then stigma too, there's a lot of stigma. Same thing, it kind of ties into toxic masculinity. Like I said, the multi-generational trauma endured by Native men, but also like within the family dynamics too. So if a child or if their parent, say, I can use my dad as an example. My dad was an alcoholic, but then his dad had abused him when he was younger, so that's why he turned to like alcoholism and substance use. So all of that was kind of influencing his like mental health, and then him being a father to us as children, he really struggled to understand like what mental health was, or why we were acting the way we were acting when we were younger, or why we do struggle with our mental health within our families. So he's kind of at that point of like, okay, understanding himself as a person and going through like his own understanding of mental health. Like that's kind of what my dad had to go through with his own experience with mental health, was just kind of seeing that his kids are struggling, like it's real, and this is something that that's not only affecting us but affecting him too in a way. And then like I said, substance abuse. So a lot of Native men turn to alcohol and alcoholism to kind of numb the feeling of their mental health illness. And like I said, a lot of like the reality with Native men is just they weren't raised in a healthy environment. They didn't really have the solid foundation to be like a more stable person with their feelings and their emotions. And then language and terminology barriers. So when we do talk to my dad about like mental health, we use like terms like depression, addiction, anxiety. So those are things that he didn't really understand. So we try to do our best to educate him. Like, this is what anxiety may feel like, or, when I'm like this, Dad, this is like anxiety. That's how it looks. So kind of making it into terms where he's understanding, but not a lot of people have that with that education within their own family. So that conversation is not always there for Native men to feel comfortable acknowledging those things. And then, like I said, household environment. A lot of Native people and Native men, kind of with my dad's situation, my dad's example, not the best, didn't have the best like parents to kind of educate them and raise them to be healthy emotionally. And then just through these events, like Indigenous people's traditions have changed. in regards to child rearing, family structure, and relationships. And then over time, certain tribes, more so men of the tribes, develop following hardships and health side effects. So some of the breakdown of the family values, so abuse of alcohol, commercial tobacco, depression, anxiety, child abuse, neglect, domestic violence, PTSD, and then just like a general loss of meaning and sense of hope. Good. Yeah. If you have any questions or if you want to share any insight or any of these topics, you can too.
Sorry, did I skip a? Oh. I'm trying to like go back and it keeps going forward. Go back. Okay, anyways, thank you, Ivana, for sharing that. I'm gonna, oh yeah, okay, that was the next slide. I know there, who else? Are there any other Pacific Islands? I can't see everyone. I can only see the slides. But just to go quickly, because I know I took too much time in the intro sharing my story, but just similar Pacific Island culture, no different. I shared a lot of the things about my own experience, and those are the same things that our Pacific Island men are experiencing, very similar to, if not exactly the same as the other cultures that were shared. One thing, when we talked about the athletes, the story that came to mind was the story of Junior Seau and how he what he experienced. Shoot, I don't know what is going on with this. What he experienced with mental health after having so many concussions in the NFL. He had gone through just so many things, but again, didn't know the symptoms, didn't know the signs, and didn't speak out about it until later on. But what stuck out to me about this is that they share, even in this article, and you can read the article on at this reference below, that it said, sadly, that which makes them so good at football, their extraordinary internalization of discipline and warrior self-image that drives them to play with no fefe, which means no fear, also makes them especially vulnerable. That again, toxic masculinity, the idea that you have to be, you can't be scared. You just have to go in and just give it your all and do the best you can, no matter what it takes. And that's the mentality that many of our men have. And when Junior Seau spoke out about this, because of the, who he is and the role model he is, so many more men were able to speak out as well about their experiences. And then I just wanted to share this. This is in Utah. Kava Talks is a men's support group that was started by Pacific Island Knowledge to Action Resources. It's a CBO, or community-based organization that addresses violence prevention and provides safe spaces for men to talk about these issues. And if you know what Kava is, the owner, or the owner of this organization decided, I'm just gonna go where all the men are, which are in these Kava circles, and I'm just gonna talk about these things with them. And when he went there, he quickly found out, like, people were like, get out of here. We don't want to talk about that stuff here. This is where we come to relax and talk about other things, even though traditionally Kava ceremonies were for conflict resolution. That's what it was for. But so anyways, it now after COVID, and that time has passed by, the more education and awareness that has been put out about the stigmas, Kava Talks now has a group every week where men are coming to specifically talk about their mental health. And so that was one way that we are addressing that, especially here in Utah. So Leanne.
Thanks, Loretta. So yeah, Asian men and mental health. Studies have found that Asian men are less likely to seek help for mental health issues than other ethnicities. And when they do, they tend to do so later in the course of their illness. Even more concerning is the fact that Asian men are more likely to die by suicide than any other ethnic group in the US. The stigma surrounding mental health in Asian culture is a big factor in why Asian men don't seek out help. The model minority myth image of Asian Americans is often perpetuated, which can make it difficult to talk about any issues or struggles. There is a sense of shame and fear of judgment, which can prevent Asian men from talking about their mental health. This stigma has been passed down through generations, and it has created a culture of silence and avoidance when it comes to discussing mental health. And another factor that contributes to the lack of support for Asian men's mental health is a lack of cultural competence in the mental health field. Many mental health professionals are not well versed in Asian culture and may not understand the dynamics and nuances of Asian families. This can make it difficult for Asian men to feel comfortable talking about their struggles. So again, like all the other cultures, it is taboo to seek mental health in the Asian American community, especially for men to seek out mental health. And there's always that stigma as well. So I think that more recently, people are learning that mental health is not a weakness. It's better to seek that help if you need it, but it's still something that our community is working on.
Thank you, Philian. Valentine?
Yeah, thank you, orator. So I think I have been listening, and it seems like we have so much in common with other presenters. I was listening to Janet's presentation. It's like really similar to our community, especially since we come from war zones. So people always have this PTSD, depression. However, traditionally, it's like seeking mental health treatment is not something that people pay attention to. It could be for the lack of health insurance and having less money to spend on healthcare. So people feel like mental health is not something that they should spend money on or they should pay attention to. But as time goes on, especially for those who have been in war zones for a long time, you can see that things are turning to worse. There is PTSD, depression, domestic violence. Recently, we have been having a lot of suicide. And again, according to mental health specialists, this is because of the things that happened in the past and were never treated. And when it comes to men, the fact that they feel responsible in the family, they feel like they have to stay strong, even if things are, the situation is becoming hard. They feel like they have to stay strong for their family and not show any sign of weakness. And all those, you put them together, they make their mental health situation worse. Some people turn into using alcohol and drugs as a treatment, but when it comes to like seeing a therapist, these are not things that many people in my community do. They don't believe that spending time with a therapist makes a difference. So those are the areas that we have been spending time on, educating people that seeking mental health treatment is necessary and important. Thank you.
Thank you so much, Valentine. I just wanted to point out in this slide, the area around trauma. Some of these things Valentine mentioned, right, in the migration of our communities to the United States, the things that they had gone through and maybe not dealt with, and then now having to deal with that on top of the new transition into this new system and everything new. Just thinking about how much trauma that is, and not being able to talk about those things. So thank you, Valentine, for sharing that. I want to go to the chat and just thank you for putting your comments in here. We really appreciate it. Just all of your sharing. Yes, you're right, Sabrina, we do need more spaces to have these conversations. And I feel like we've seen more spaces come up now for community members, for them to talk safely or with trust about these things. But we'd like to see more. And then Edwin, we have a lot of CHW males in this group. I wish they were here so that they could share their perspective. But in the workforce, we do have an increase of male CHWs coming into the field. It is very female dominant, just because of, again, those gender roles, right? This naturally was the role of the women to help, to reach out and help in community. But we have a lot of male CHWs who are now entering the field, who have, dealt with a lot of these things. I want to remind everyone that the expertise of the CHWs is that their actual lived experience. So many of the things that we're sharing, if not directly impacting our families, it is what we're seeing in the field with the community members that we work with. So thank you for your comments and your questions in the chat. If you felt like a lot of the information we shared was repetitive, it's because it was on purpose, like, because we just want to demonstrate that mental health, again, no discrimination across all cultures, across all ethnicities. If you looked at the data that we showed about older males, Caucasian males having the highest rates of suicide, this has no barriers and boundaries when it comes to the impact it has on our males. And so we really want to have more discussion about this. And in the last slide, it will just give some advice on dealing with mental health struggles. And I want to say, please go and look at the slides, but I really want to open the time to all of you, especially our males who are here, to share some perspective and thoughts around what has been shared, and anything that you are thinking about as you have been listening to the presentation. Tatiana, please time check if you can, just let us know. I wanted to make sure we had time for them to share.
Yes, so we want to finish around 6:30. I do have some questions. Please send me your questions in a private chat or in a public chat, and we'll address them. And we are set to finish around 6:30. If we finish earlier, that's okay.
Okay.
I just want to add something, Loretta. There is a slide that you put, like, where women in yellow and men in blue. And that is because more women attempt, but not succeed the attempt of suicide. But men, they are more little. They are not many attempts. That's why the statistic is different. But it's because of that, because women are more attempts, and men, they are more to go through the, I don't want to say success because that's not a proper word, but they committed more little. That's why they died. Yeah, that's the difference between the statistic.
Thank you, Jeanette. Since we have a little bit of time as you're thinking about things to share, also CHWs, if you have other things to add, this is just some advice around dealing with health struggles. So seeking information from legitimate sources. A lot of times our community members have shared with us, oh, we were given this number, or we were given this resource, one of the effective things about the CHW work that we do is that we don't just give numbers and websites to call. We really vet these things out before we provide information. And so you'll see some of that information on this slide, but also you can find online, but make sure that they are vetted resources. Take care of yourself. Self-care is something that we promote all the time. Again, our CHWs are not just serving community, we are community. So we have dealt with a lot of these things and understand the importance of self-care, implemented in our daily lives and daily routines, not the every weekend, the every weekend pedicure or outing that you have with your friends or your family. It has to be something that's implemented on the daily if you're not seeing someone for help. Just connection with others is very important. And then doing things that will help you relax, like meditation, walking, all of those kinds of things. And then asking for support. That's why we're doing a lot of this awareness, is because we want people to feel safe that they can ask for support. That's been something that we've heard many a times from men, that they were ashamed to ask. They were ashamed to admit that they needed help. And so we just want to make sure that these things are shared with all of you. And then if you have people with children that are dealing with these struggles, these are some tips to help them. Again, the exercises of self-care, listening, reflective listening, and then providing resources that they can connect to. And let's see, I see in the chat, are you posting questions from everyone or just questions?
From everyone. Let me start with this one that I haven't pasted yet. Often
Okay.
the burden of improving mental health falls to women. We have to convince our partners, sons, brothers to seek help, and often men have weaker social networks and rely on the emotional labor of women. How can we empower men to take charge of their own mental health? I would say the first thing is talk about it. Talk about it. Talk about it at your table. Talk about it over Thanksgiving. Normalize it.
Mhm. I would also add to try to share family responsibilities as much as you can, so that men has also time for self-care.
I will say that probably if something like that is happening in the family, I know that is not the responsibility on the women or other people in the family, but remember that the person that is suffering, they don't see it. They cannot recognize that they have it. And in my family, I have my son with anxiety, social anxiety, and my husband didn't understand that. And it was so conflict. And what I did is I took the peer support training, I informed myself, and then I bring that information to my house and put it in the restroom, in the toilet, as books, as pamphlets, because everybody, when they go to the restroom, they like to read something. And I put that all the time until one day, my husband get out of the restroom and said, "Oh, did you read this? This is exactly what my son had." And I said, "Yeah, finally, wow." And it has to start from somewhere, because if I wait until he finalized, see what is happening to him, sometimes it's gonna be hard. The stigma is gonna grow more. It is better if you see something like that, bring that information to your house and say, I read this and I see that you are feeling like that. What do you think? Start those conversations in the family and bring that information to the house, because sometimes the person that is suffering, they don't see it as a depression or anxiety. They see like, oh, I'm tired. Oh, I'm stressed. Maybe I'm working so much, and that I know that is not everybody else's responsibility, but if you have that information, you can recognize and share with them.
Yeah, I think that communication is huge, and normalizing the discussion of these topics has to be the first thing that we do. I think everybody just has this silent understanding that, oh, this is taboo, we don't talk about this, and so nobody talks about it. I think even my sons have picked up that, oh, there are certain things you don't talk about and certain things you can't talk about, and there's a time and place for these discussions. Just not even by us saying it, just by their experiences in culture. And I'm looking at the questions. Maybe I'll just let Tatiana ask them, but I'm glad that you brought them out, because if you notice in the common thread and pattern of our discussion, a lot of these things around mental health have come from the cultures that we come from. Not just our ethnic culture, but our upbringings, and understanding the roles of men and women, and the pressure and the understanding of their role to be masculine, to be the provider, to always be strong. That is a cultural thing that's come up. But if you look at the other, what's behind a lot of that, it's the culture that we come from, and the historical culture, and the impact of these things that are in this question around racism, around systemic racism. All of those things have an impact on that as well. So if you guys want to talk about things around the root causes that I feel like a lot of this stems from.
Thank you so much. While I'm reading all these ideas and typing, I can't help but think of the mini grant we offer for community-based interventions. So there I put some tips and hints if any of our students are interested in thinking outside the box and creating or starting to pilot something. We have the mini grants for AHEC scholars. Okay, here's another question. After listening to this awesome presentation, it seems that one of the biggest barriers is men not opening up about mental health. How can we break this barrier? How can we approach men of different cultures to open up about their mental health disorders?
In my community, I know men talking to men, having the man on man without a female in the room, without a female anywhere around, can be very powerful. Men that have a shared background, a shared, culture, it can be very powerful when you get around, men with men. I think that's a good, first step. That could be a good therapy.
Yeah. Can
Yeah.
I add something up? Well, I can only say from like Native perspective too. So like kind of what Kathy was saying, that like male to male conversations, male to male like bonding experience. So within the Native community, some of that could be like powwow dancing, like singing and drumming together in drum groups, also like talking circles too, and then like even just like physical activities. So like a lot of Native men participate in like basketball tournaments, so having that shared space, and then just like in ceremonies too. So like sweat lodge ceremonies, or if there's elders there that are talking to the younger kids, and kind of having the opportunity for men just to like discuss, pray together, and just encourage each other. Like even if it's just not like, hey, I'm not feeling good, it's more of like, yeah, that's good that you're talking about it, or it's good that you are here, we're glad you're here. And just kind of like that reassuring them that, their presence of them being at the ceremony or being at the basketball game, being at the powwow, recognizing that that's a huge part of like Native community, or like Native connections that, not all Native men could see as it being helpful to their mental health.
Thank you so much, Ivana. Another question. How can I utilize CHWs in my practice in order to address mental health in males? What do you see as the role of the CHW?
I think for us, I could see us correcting stories from people who were seeking treatment and they got help. I think putting all those stories together and share them in the community so that others can see that it works. It could be maybe seeing a therapist or doing like the traditional things that Ivana was talking about. So collecting these stories together and sharing them in the community.
I think also if it's a medical practice, the CHWs are really good at connecting males or are starting these kinds of conversations as they build trusted relationships, and then connecting males to groups or to resources where they can seek help or get peer support from. CHWs are very well connected in that way, and their trusted relationships really help to talk about these very taboo topics that most people are uncomfortable to share in a provider's office or even in a therapy session.
Here's a difficult question and maybe something to ponder. We might not have an answer, but how can we navigate calling emergency services or 911 or the police to respond to a mental health crisis of minority men? It can be such a scary place. And on a side note, as somebody that was a minority was having a mental crisis, and the first instinct was to call 911, and immediately the room is like, no, do not call the police. Any feedback from our CHWs?
That's very scary, to add anxiety on top of whatever he's going through at the moment, especially, the last few years where it's been all over the news, where you're calling for help and they come and kill the person, or, it's scary. And you're hesitant. You don't want to do that because you don't want them to die. You want them to get help. And so it's that's sticky because, if you cannot send a social worker or someone with that kind of background to come and help me, then don't send anyone, as far as the police go.
I will say that we have been trying to, and we've that conversation has gone. I mean, we need to pick it back up, but in the beginning of the year, and especially after pandemic, we have had discussions with law enforcement to better train our law enforcement on how to deal with these calls. And then we also have been trained as CHWs to look at some of the resources that I'm sharing right now on the PowerPoint, so that we can direct them to the right places for support. But in any case, for me, if it's a situation and I don't know, what level of they're at as far as their fee goes, I tell them to call emergency services, or I will call and facilitate that conversation, only because we've gone through that training. But it's, again, like Kathy said, a difficult call to make.
Thank you so much, Oretta. I can't help but thinking of all the new Americans arriving, because it says recognize and address socioeconomic factors that contribute to mental health disparities in minority communities, such as unemployment, housing instability, education inequalities. All, I assume, are experienced by our new Americans arriving here. To keep in mind when we have those patients. And Sabrina sharing the mobile crisis outreach. Sabrina, can you tell us a little bit more about that? Is it a number you call, and what happens when you do?
Yeah, it's a team ran by the U, and so it consists of counselors, and their availability does vary. Always an excellent option, but you can reach out to them and they'll send a team to you to talk to the person who's going through a crisis. And they can usually help set up referrals or just spend time talking to the individual. So it can be a good alternative to the police.
Thank you so much. I don't know if many of you are aware that the scripts for 911 calls are developed here in Salt Lake City in a specific business place that does the what the script for the people that answer the phone. And they reached out to the University of Utah before the pandemic in order to conduct focus groups to learn the barriers of accessing 911 for those that are not originally from here or English is not their first language. So it'll be interesting to find out what's happened since COVID. I'll try and dig it out and post it for our scholars and our CHWs.
I really would, I think, as we have shared, this is a very female dominant field of CHW work, and you can see that in who's present here. I really would like to hear some of our male perspectives around what has been shared and just your thoughts around this, especially, we've shared what we've seen work as far as like males speaking to males and just the activities and all that they can do. But what is your perspective on this, and what feedback do you have for us? Any thoughts or comments? This has been something that I found effective in again my working with the males, is that a lot of times we will have these conversations and it's all women saying what we've experienced, but I don't know if it's just processing a lot of it or sharing, but every time, so the male that I talked about for Kava Talks, he's an actual CHW. He used to serve on our CHW leadership team. His name is Poteki, and he is who facilitates a lot of the discussions in the Kava Talks males group, and just he's very cautious, like self-cautious about his language because he doesn't speak very good English. But when he speaks, he speaks volumes. Like everyone is always either crying or has felt so touched that that's how we've gotten more males involved in helping to facilitate these discussions. Edwin's saying, my microphone is being weird, but I think that call-in is really important to recognize who is presenting and who is missing in the space. I'm a male social worker, so I definitely get the need to increase representation. Yes, it's so true. If you also haven't heard, there's a group called Day One. They are a group of males who have been incarcerated or have been, just dealing with a lot of struggles in their own lives, and they've come together to form a group that wants to go out and help our youth to know. I mean, again, we're looking at different generational experiences, right? Many of them who have been incarcerated and come out had a different experience, and so they're trying to say to their youth, the boys who have looked up to them, thinking that this is the way they're supposed to be. They've been speaking out and sharing with our younger youth and men that you don't have to live that life, that it's a different time now, and they're speaking out about their experiences, and it has helped so many of our younger youth. If you remember the shooting that happened at Hunter High School, it has helped a lot of our younger youth males come out and speak on, just that experience, and even the judgment of that, all of these youth boys from these cultures are like that they have these issues. And we had a group that was facilitated by Day One and by Kava Talks. And the young men shared, we want to speak about these things, we just don't know how. And we especially don't know how to speak about these things with our dads. And again, this was when it was facilitated by the women, we didn't get a lot of feedback. But when these males came out with us to speak on their experiences, we got so much response from them. So representation is really key.
We have learned so much tonight. Thank you so much to our CHW. Do we have any last minute questions? Please consider doing a research project with the funding, applying for our funding, the mini grants on the AHEC Scholars, on the AHEC page. I encourage you to do that because as I could see so many ideas that could be a pilot program for some of these communities. We want to thank Ms. Oreta, Kathy, Felian, Valentin, Ms. Sara Carvajal for their time tonight, leading this group as CHWs that are working for AHEC. Please feel free to reach out to them if you have further questions. Oreta, would you please share your email on the chat as the lead of this discussion tonight? They're all leads and leaders in their own community, but for ease of communication, let's say you have an encounter with a patient that doesn't quite go as planned, or that you are at a loss for ideas or referrals, please reach out to these community health workers for help and for advice. Thank you so much, Oreta. Any other thoughts? Thanks again. Please don't forget to fill out a form, a Google form, to get credit for your attendance. Please remember we have many other topics covered in our YouTube channel. And if you watch any of those, they can go to our selected credit after you fulfill the first 2 viewings that are required. We look forward to March for another exciting topic. And we're grateful to keep this a safe space where we can unlearn and have difficult conversations and grow. Thanks again. Have a great night.
Thank you.
Thank you.